is Judy Alter, and I'm interviewing Dr. David Richards on August 31st, 1989.
Okay, the first question is what attracted me or interested me in the Texas College of Orthopedic Medicine? The thing that interested me most was in 1980 when I first reviewed here is the fact that it had the most potential of all the osteopathic schools, in my opinion. It had funding, it had legislative support, it had facilities, and it was associated with a emerging state university, North Texas State University at that period of time, and it had potential for expanding the opportunities in the purest sense of academia, period. As you know, there are different types of osteopathic medical schools in the country.
And you were at Ohio at the time, weren't you?
I was at Ohio at the time. In fact, I helped start the Ohio College. I was the second position hired. I was on the planning committee to help establish that. But what I saw was a young institution had the full commitment of the academic base, had the full commitment of the Texas Osteopathic Medical Association, and close proximity to the primary teaching hospital, and I saw nothing but potential for the institution, and I wanted to be a part of that growth. And the strengths of the institution, the strengths are some of those that I've just mentioned. The weaknesses at that point in time is that we did not have a research base per se, and one of the first things that I did was to establish that. And by the way, I named Joel Alter the chairman of the committee. I remember Joel. I didn't see a lot of planning. I didn't see a lot of direction.
Not in the overall institution, not just in research.
Right. In the overall institution. I equated this hospital, after I made my initial assessment when I was on board, as an institution that, the analogy was a proprietary hospital in the 50s that was established by a surgeon and an internist and whatever, and it was a family hospital. It had 30 beds.
Mom and pop.
And it was mom and pop. And they knew everyone. They took care of things. They socialized. And it was a family in essence. But now, with 1978, with brand new facilities and a periphery of faculty and staff coming on board, the communications link did not keep up with the sudden growth of the institution. And that related not only to the relationship with the private sector across the street, but within our own family.
I'm going to back up to research for a minute. Is it not traditionally hard to start a research program in an osteopathic institution?
It is, because many of our graduates, and those even that are residency trained, have not trained in academic health centers, where they had responsibilities for being a part of research programs. Okay? On the other hand, our PhD colleagues have had that experience, and they took off running. Okay? And there are very few osteopathic medical schools in the country that have external funding. In fact, some of the osteopathic schools have very little external funding.
Even today?
But some of the state schools do have. I think that we're among the leaders in research. We started with an insignificant amount of dollars back when, and we're approaching almost $4 million per year in aggregated research. That's a long ways in comparison.
And And that is not just basic science research, but also clinical.
We're in the clinical research, which includes some funding for the Kellogg thing, which is a landmark for the institution. What are the problems? The problems I just mentioned, but also the problems were, at that point in time, and I predicted that in 1981, that with the growth of the institution, in spite of the facilities planning that we had, that space would be a problem. And we are at that point at this point in time. We're running out of space. Major concern is that. Some of the other concerns that we have is our lack of quality graduate education programs, the proliferation of these programs available to our graduates now that they are competent and are receiving national recognition in terms of their credentials. What are the other problems that I could think of? It's a global problem that relates to the single most important factor that we face is, as medical educators in general, is where medicine is going. The high healthcare costs and the perception of the high healthcare cost is the single most important factor that relates to where medical education is going. The RGs are cutting back in terms of graduate medical education programs. Small hospitals are closing, and small hospitals are in fact one of the differentiating factors in the orthopedic profession. Many of our graduates have trained in community hospitals throughout the United States, 100 and 250 bed hospitals. Much of the graduate program in the orthopedic profession has been in those kind of hospitals, but they are closing. So now we as medical educators have to plan for that closing, open up new avenues of opportunities in order to ensure and enhance graduate medical education. The profession is looking to the colleges for support and commitment to graduate medical programs, which is something new.
When you say the lack of quality graduate education programs, and that's not really a TCOM problem, it's a DO problem.
It's a DO problem. There's a study done recently by the American College of Internists in the last Orthopedic News Journal, where they surveyed 156 graduates who have gone into allopathic residencies. And what they determined was that it was not just a stipend. It was the lack of patient volume, and it was the lack of structured quality graduate programs in certain areas. And what we have now is we have competitive graduates. Okay? They can stand on their own.
For the first time?
I don't know that. But consistently, they can stand on their own with any graduate from any medical school. And they're wanted. And they're being recruited. And that's not only this school, but other schools as well. Okay.
Back up and tell me about the Kellogg grant. I obviously have heard, but I don't know totally.
Kellogg grant is a unique grant. We were told that we, as an institution, needed to have funding from a major foundation, and Kellogg and Ford Foundation are some of the biggest in the country. So back a few years ago, the initiative was taken to get into some planning mode to find a niche so Kellogg would fund us. It started out with something with wellness and prevention, and that never worked. We started out with 2 or 3 other initiatives, and that didn't work. And Charlie Ogilvie came up with the idea of the community-oriented primary care perspective. At which point, some of the people here contacted PhD in nursing, Dr. Renee Courtney from UT Arlington Nursing School, who worked together with Dr. Baldwin and some others here and came up with a proposal. At which point, it went to Kellogg. Kellogg made some site visits, and they funded us for $1.1 million to be given upon matching of another $1.1 million. The reason that they did not give us the full money is that Kellogg felt that the Texas foundations are very protective of funding Texans, but yet this is a Michigan foundation, and they felt that we should raise money internally because of the attitude of the other foundations. And I don't know if that's something that you want to publish, but in reality that's what happened. At which point, this was to involve the inner city. It's involved a research program to determine that really it's a community partnership in the healthcare delivery system. And if you cooperate with the medical students, with the nurse practitioner student, and with the nursing student, and the osteopathic physicians, that we in fact can influence healthcare delivery in a significant way by that partnership. For example, if you're into a community like the North-South community, and you find that diabetes is prevalent, or you find that hypertension is prevalent, or you find that scabies is present, whatever it may be, that there's a mechanism to involve that community in helping solve that problem through awareness. And, we recognize that the single most important preventive factor we have in the AIDS situation is prevention. So we're very excited about that, and we think that the Kellogg proposal will continue and expand to Justin Clinic.
It's going to start on the north side.
It's going to start on the north side, and Dr. John Peckham has got the responsibility to make that happen. Remember John Peckham?
Yes, I've talked to him recently and frequently.
Okay. What else in Kellogg? It's exciting, and we are a player.
It is a major step for the institution.
It's a major step for the institution. And you need to put down there, what are the benchmarks as a question at the end. Maybe I should do that.
I've got signposts in the history of the school. That's
fine. That's it. Okay, what else on this? What was your background in osteopathic medical education? Okay, I'm a DO. Graduate of the Kirksville College of Osteopathic Medicine in 1960. Interned at Doctors Hospital in Columbus, Ohio in 1961. I practiced in a small town north of Columbus, a town of, at that time, of about 5,000 people, Worthington, Ohio. And I practiced in that vicinity until 1976, at which point I helped start the Ohio College of Osteopathic Medicine. I was put on the original curriculum committee that established the college, and I was offered a job as a founding chairman of the Department of Family Medicine in 1976, and I took that, and then I became the Associate Dean for Academic Affairs and Associate Dean for Academic and Clinical Affairs, and left there in '81 to come here.
And I remember having dinner with you and Joel and Jay.
Jay, Lola wasn't there.
Lola wasn't there. We were all in the Century 2 Club.
That was in 1980.
When you came to visit.
We came to visit. I was invited down here to be chairman of the Public Health and Preventive Medicine Department by Dr. Baldwin, and decided that that was not my niche, and went back and continued doing what I was doing. Then I interviewed again. There was a job opening, and I was called, and I was made aware of that. Associate Dean for Academic Affairs. Interviewed for that, and I started April 1 of 1981. I became the Dean for Academic Affairs. And remember that I was not the Dean of the college at any time. I've never been dean of the college here.
Did we have a dean of the college at the time? But we didn't have a president then.
We had a president in 1981. The president maintained the title as dean of the institution and president. It's a very important point. He was president and dean. All academic decisions were made by the president. And one of the first things I did when I became the acting president was to separate the deanship and the presidency. We have a dean. We have a vice president and dean for academic affairs.
Which is Dr. Zachary.
Correct. What do you see as a particular strong points of the educational program at TCOM? I think that we have a particularly strong liberal arts of medical education curriculum. People don't like me to use that term. They think it's not a good term, but I can't find any term that's more descriptive.
Does that go back to John talking the other night about we went through a spell of accepting people without the strong scientific background because we wanted people with other kinds of skills? Is that all part of this making the rounded physician rather than the tunnel vision scientist?
Yeah, I think it is, but it means more than that. The analogy that I would use is the fact that, let's say we have a lecture that's on pediatric oncology, pediatric cancer. Majority of those lectures, if it does exist as a lecture, and I'm using this analogy, would be given perhaps by the pathologist, the pediatrician, and the oncologist, okay? Not the pediatric oncologist. So the approach is different, okay? The other thing is that our program does not say to the medical student, look, you've been here 2 years in medical school, now's the time for you to make your choice. I've got a slew of electives here. Let's if you're going to be an internist, then take your electives in internal medicine for the next 2 years. Okay? If that's what you want to be. Versus if you want to be a surgeon, take your electives in surgery. We have a core rotation which is required. Okay? And we do have a few electives. But we're not saying that student, we do not ask them to make a decision on where they're going to be after a period of 2 years. So in fact, they will go through pediatrics. They will go through internal medicine. They'll go through surgery. And I've had students come and say they'd like to be an internist, and then they go on pediatrics and they want to be a pediatrician. And I heard them say they want to be a surgeon. Then they go into surgery and then they want to be something else. And we feel that's good because we're producing at the end of 4 years the community physician. And that doesn't preclude the fact that community physician that's trained after 4 years will then take an internship, which again is 12 rotations, and then go into the specialty of his or her choice. And that's an important point that I feel very strongly that anyone that's graduating today has to be residency trained in order to have privileges down the line.
In allopathic schools today, do they make their specialty decisions sooner? Is there
In my opinion, they do.
In other osteopathic schools, do they?
Don't know that. I feel that they have core rotations as well, and at least the philosophy that's emulated by the other osteopathic schools is the well-rounded physician, and then they can take their graduate programs. And what is particularly the strength? The fact that we have a location where there's so many unmet healthcare needs. Okay? Inner city, rural, and suburban right here in Fort Worth. And, latest Tarrant County health survey, where 90,000 individuals this year do not have health insurance, of which 45,000 are children, and where 59% of the people polled were not aware of any wellness and prevention aspects upon advice of their physician, puts us at the right place at the right time. I think that as an institution, we could not be in a better place at the right time. In meeting with one of the senators at breakfast a couple of months ago in Washington, he was sitting there with a conglomerate of representatives from the American Medical Association, from the Physical Therapy Association, from the Ophthalmological Society, and whatever. There were about 15 of us. This Senator Hines from Pennsylvania says, 85% of the medical school graduates do not know anything about wellness and prevention. He says, for the rising health care cost and the state of the Medicare and Medicaid and the insurance industry, there isn't anyone who on the Hill who doesn't recognize that fact, and that there will be initiatives that will relate to this. Something to that phase. They recognize that 85% of the graduates are not trained in nutrition, health assessment, and aware of wellness components as a measure to help reduce healthcare costs. On the other side, third-party pay does not recognize that, which is a problem. Okay? You're feeling well and you want to go in and get a check over this or that because of whatever. Third party won't pay for this.
I thought to some extent they were.
Very low. You can ask John.
I think I just thought that because they pay for mammograms 100%.
There may be few exceptions. But certainly not for a nutritional survey or a lifestyle inventory or those type of things. I think that I was told by one individual that they brought together Forbes 500 companies, 10 of them, to Washington behind closed doors. And I was told this by the head of the Medical Service Corps, and he was asking me, I was giving a speech at one point, he says, what do you think about healthcare costs? And he said, in his meeting, those people told him that they wanted a physician that would take care of the majority of the problems and not have to refer to 5 different places for 10 different tests. That's that's raising healthcare costs. Okay. Well, the reality is that we're producing that kind of physician. However, malpractice and the tort reform and defensive medicine fits into that aspect. That has to be changed in order to help reduce healthcare costs, from my viewpoint. I think the strength of the educational program is the commitment that the institution has towards excellence. And I think that there isn't any faculty here who is not fully aware that we're striving to be the best. And I think that relates to the students as well. It can be contagious.
Yeah. Filters down, for sure.
What distinguishes the clinical program from other osteopathic institutions? I think that the 3 months in general practice, I think that we are training in community hospitals. I think that in all reality, we do not have the strongest clinical program we should have.
Don't want to say that.
No. But
we'll continue to grow.
It will continue to grow, and will continue to grow by continuing to hire outstanding faculty who are committed, and expanding our affiliation base and more graduate programs, which means better teaching programs because residents teach. And do you have the fact sheet at the college?
I do at home. I didn't bring it with me.
But you've got the fact sheet,
Mhm.
okay. The recent fact sheet that Warren Anderson produced.
That Warren and Bill Hicks did. I think
Yeah.
it's the most recent one.
Okay.
Yes. It was done like a year ago.
Fine.
Yeah, I think it was done. Does that sound right? A year ago? More recently?
Mhm.
I'll check.
What distinguishes the research program? I think that we're generating about 75,000 dollars per individual in our research area.
Per individual, what kind of individual?
PhD, which is probably very high in comparison to the other medical schools. I think that what distinguishes us is the caliber of our faculty. For example, Dr. Bob Gracie received $3 million in the next 10 years for his work in aging. Significant cancer research. In fact, our people are working very closely with Alcon Laboratories on a partnership level. We're teaching there in some programs. We are internationally known researchers. Our people are going all over the world lecturing on their areas of expertise, particularly in biochemistry and physiology and pharmacology. These are national figures and international, with an international reputation. And we're starting to have some of those people have joint appointments in our clinical departments in order to assist our physicians in developing that clinical base.
You mean pulling the research people into the clinical departments to...
Yeah.
What does a physiologist do in a clinical department? In
Well,
teaching, you mean?
Helping with research projects and also
Okay.
teach. Much of internal medicine is pathology, physiology, and pharmacology. And we have several PhDs. One biochemist, another research writer, a grant writer, and Dr. Shields, physiologist, is in there, and our cardiologist, Dr. Fisher, is doing things in cardiology that, based on his training, that are very much related to physiology. Developing that research base. The difference, there are three things, the three stools of academia that differentiate physicians here from the physicians in private practice. One is a commitment to teaching. I feel very strongly we don't teach much. We create learning experiences. Two is the area of scholarly activity. As a state institution, in 1986, when the governor said the state is in trouble economically, Governor Hobby said that the oil and gas windfall is over. Now it's high technology and research, which is going to take the place of those gifts that higher education got from the oil and gas money, which gave us direction. Gave us direction and initiative to do some things that need to be done. Okay. I'm not sure I have on the top of my head any other answers to that research
Okay.
program, but I'd suggest that you meet with Ben Harris to explore that a little further. And that's an important area. Okay.
I think that Ray is interviewing him.
Okay. What are the significant signposts in the history of the school? I can't speak before 1981 because I don't know.
You know, there have been interviews done up until about 1984, and I have really a pretty good bunch of material up until at least 80. But after this history since 1980.
Okay.
When did you take over as president?
Interim Executive Vice President, November 16th of 1984.
84. Okay, so we've got a few years to pick up before that then.
The first signpost was that TCOM, they created a president for the institution. That was an important step in terms of giving us the opportunity to do some things Ralph Willard and whoever succeeds me as relating to other people with the same credentials throughout the United States.
When was that?
It was in 1981. I don't remember the date. It's May something. The Board of Regents created that position. And remember that the reporting lines that I report to the Board of Regents of the University of North Texas through chancellors. You have the chancellor, he's the president of the University of North Texas, and chancellor of us. In terms of the signposts, I think that the establishment of the research base in 1981 was very significant.
How can you, what one event marks the establishment of the research base? I mean, how can you
The
say?
the committee that was established.
Oh, the one you were talking about that Joel was in.
Yeah, and one of the first things I did, I felt I had the authority to establish this committee. I got in a lot of controversy because I established it after the fact. And I don't want that on the record, but just for your information. That was important. And what it did was make a needs assessment of our institution in comparison to our resources that we should be moving in a separate direction.
And I assume it was a committee of DOs and PhDs.
Right, chaired by Judy Alter. The second thing is that we negotiated at that point that there would be a associate dean for research, and established a search committee, and it was Ben Harris was named as that associate dean for research, and giving that license. It just took off, and we started to hire people who were well qualified in that area.
I, of course, have this at home, but I forget. What year did we occupy Mid-Ed 2?
About that time, about 1980, 81 to 82.
Did the physical facilities also help with the hiring of qualified?
Absolutely. The physical facilities gave the individuals par excellence space for them to conduct research in an organized fashion. Absolutely.
And made us more attractive to the caliber of people.
No question. No question. The other signpost was in 1984. We were in deep straits.
Is this Flex?
For a period of time, we had taken in the students who did not have good MCATs, who were wonderful people who did not have the GPAs, and we had for a period of years, 11 and 12% failure rate down the line, you know. And all of a sudden we had a 21% failure rate, and the legislature and the Board of Regents asked a series of tough questions on why. And they wanted it resolved. And that's when the 39 points came out. And those were 39 points are the template for academic excellence that was approved by the Board of Regents November 16th of 1984, along with the restatement of the goal statement.
Restatement in what way? Off the record, my understanding has often been that the goal statement took us so far from traditional medical teaching that then the students were not prepared for the traditional medical exam. No?
That may be a factor. Okay. May I suggest to you that...
Remember, I get it all filtered way back.
Yeah. Let me suggest to you that that may be a factor. But when you're taking in students with 23 and 30 MCATs, and you're competing against institutions with 50 and 60 MCATs, it doesn't work.
So it really was an admissions policy problem.
The most significant problem was the admissions policy, the liberal admissions policy. You know, there were students, wonderful people, who were very osteopathic oriented.
Yeah, but they were also theology majors, and I remember that, looking at the list when I worked here and thinking, golly.
Well, you know, taking a theology major, again, there's nothing wrong with that, providing that they have the GPA, they have the science GPA, and they can read. If you were to ask me today, and looking at this over a period of time, the most significant factor that we have that's consistent in failures on external exams, it's the reading factor, reading comprehension. Okay?
You have a person here who is skilled in teaching that, do you know?
Peggy Dansrose.
Yeah, is that Peggy's daughter and my daughter have grown up together or something? But is that not unusual for medical school?
To have a reading specialist? I think that other medical schools certainly have support. We have a variety of support systems. But the decision was made at that point in time that we would raise our academic standards to minimums. And this has been a major controversy with the profession even today. You know, why don't you take my son and daughter, who's a wonderful person and committed to osteopathic medicine?
I remember that when I was a teenager. What do you mean my son is flunking out of school? Very difficult spot to be in.
We face this continually. And our decision is to uphold the standards of the Board of Regents. And so far, it's paying off. Okay?
I somehow think that's a more difficult stance to take in the osteopathic profession, because although we're going away from it, we're still a family profession.
My son and daughter deserves to be in the state institution for which I pay taxes in.
Well, that's true.
And they will do fine. Okay? But they don't have a 40 MCAT. And a 40 MCAT is a minimum. Okay? That's the lower 20% of all medical school applicants in the state of Texas.
Is the pool shrinking? Are there less applicants now than there were?
There are, nationally, there are less applicants, and particularly in minorities. Major problem in black. But this is a national problem. In terms of enrollment. However, we're very fortunate in we think being at the right place in the right time. The initiatives and incentives for primary care nationally are going to put us in the right place. There's still, all these studies on health manpower, that there's going to be oversupply of physicians, in my opinion, is a bunch of malarkey. In fact, Eli Ginsberg in health issues that came out about a month ago said that in the original data that they used to determine that there was an oversupply in the Gemini study, which was the first one that came out in the late 70s, in fact, the error was like 250,000 in terms of the count. So he is probably the expert on health manpower in the United States, former dean of Harvard Medical School, and had federal appointments and stayed attuned to this. His feeling is that you can't predict that. Look at the nursing profession. We had an oversupply of nurses. Headlines. We have an oversupply of nurses. Now we have an undersupply of nurses. At one point we had an oversupply of engineers. Now there's an undersupply of engineers.
SMU's going to help cut down on that.
There's an oversupply of teachers. Now there's an undersupply of teachers. What goes around comes around. I suggest to you that you take a circle around Fort Worth and go 50 miles in any direction, and you can find significant needs that are unmet in healthcare, as well as in the inner city, for our type of position. The other signpost, that was one. The other one was in about a year ago, 2 years ago, there was a special committee in higher education looking at the role and scope of institutions. Do we need as many institutions? What are their quality? Well, they couldn't deal with medical schools and allied health programs and nursing schools, so they submit the governor and lieutenant governor, the speaker, I guess it's a lieutenant governor and speaker, selected a committee to review medical schools, dental schools, and nursing schools. And they spent a year going from campus to campus and asking questions and looking at data. And that was a significant, what I call, tiering of the institution.
TIER.
TIER. We tiered up a level because it created a better understanding with the other medical schools. It created a better understanding in the legislature that we, in fact, were credible. We had a unique perspective in relationship to the other medical schools, like Baylor and Southwestern, perhaps are research institutions. Well, our mission is to produce community physicians for areas of need in Texas. That's unique.
That is still our...
And you need a copy of the mission statement.
Yeah, I do need a copy of
Let me write that down. All right. That was a major stepping stone. And the chancellor was the one that said, when history books are written, David, that will be the single most important factor, and he'll tell you that when you interview him, in his regard to the institution. The other thing I think that's significant is the fact that we cut a deal with Carswell. I received an award on behalf of the college at Keesler Air Force Base a couple of months ago by the head of the Medical Service Corps of the Air Force for taking the ball and running with it. Seeing that there are needs at Carswell, creating a community partnership, which is the envy of many installations, and using our resources in trade for educational opportunities.
So that gives our students a whole clinical body for practice work.
in our residence, and we're doing surgery there, you know. And these people are being taken to Fort Worth Owen and doing surgery. It's significant. The other thing is the relationship with the VA.
When did the Carswell deal?
I cut that deal about a year ago with them.
Yeah.
The VA, I sat on a federal committee, the Special Medical Advisory Committee of the Veterans Administration, and cut a deal through our legislative people, Jim Wright, and Craig Gropp, who was a former Board of Regent, and cut a deal that were involved in the ambulatory care base here in Fort Worth with the Dallas Medical Center and VA Medical Center in Dallas. We also were approached, and we will sign an affiliation agreement with Sam Rayburn Veterans Administration Hospital in Bonham, Texas, which is 2 hours away from here. So now we have our foot in the door for an educational base in the Veterans Administration, which is significant because the hospital profession has not had a long history in establishing these kind of affiliations. And the reason that we are having this opportunity is the fact that we're being recognized as a national figure now in medical circles as a whole. We are a player in the system.
That's the whole thing, isn't it? To be a player in the system, to be part of it, and hasn't been in 20 years ago, wasn't. Yeah.
We are a player. I think that the other most significant thing that's happened is that for the first time, the state of Texas recognizes us as a player. Our budget was 14% increase this year, higher than any other medical school. Why? Because they recognize the contribution we've made and the job that's being done. They came to us and said, would you like to be part of paternity testing? Okay. This is a landmark. Why is it a landmark? It's a landmark because now we're in the DNA business.
Did you say paternity testing?
Paternity testing for the Attorney General's office. Because there's such a need. There are 50,000 cases in the state of Texas of illegitimate pregnancies, of which there are a backlog of some 400,000 cases in the court system, which relate to paternity testing.
It's an astounding comment in our society, isn't it?
Well, you know, and you're living in a town that in 1985 had the highest infant mortality rate in the nation. The significant thing about paternity testing is that now, instead of being a training program for medical students and residents, we are asked to be of service directly to the state of Texas in a very interesting, far-reaching potential program, which is DNA testing. Okay? Now, DNA testing has an academic base, a research component, let alone the potential for diagnosis and treatment in certain cancers. It's state of the art. And not to mention the fact that University of North Texas has a criminal anthropology component, which is identifying remains of bodies that have been out in the field for months and years. it gives us potential to be involved in the aspect of criminal investigation. And you do know that we have a partnership with the forensic Tarrant County medical examiner's office on our faculty have time. So we are now into a different arena.
Does the Tarrant County medical examiner not have facilities on the cases?
No, they are now on John Peter Smith.
They did have it one time, didn't they?
For many years. And he asked us at one point if we wanted to give him land, put a building, and I said no. I talked to Judge Moncrief, and he didn't want that to occur. But we still have a relationship, and that relationship will continue to grow. Our people cover that. Those are the major signposts since 1984.
As the school grows, the signposts become a little less tangible, a little more complicated. It's not simply moving from one building to another.
The greatest strength that we have, as I see it, is in the people who are here, the students, the faculty, the staff, the commitment. We have a very low turnover rate as an institution, attrition rate. People don't leave. Very few people leave, according to our personnel group. The greatest strength that we have is that we are a young medical institution that has flexibility to initiate change, were that the choice. We aren't established in the 50, 75, and 100-year traditions of what or how.
That, of course, is the point that I tried to make in the early thing. Even in the early years, the strength of this institution was the people who overcame, and I think there's a tradition of that flexibility because there were some very creative solutions.
Yes, and it has to be. It has to be. We don't want to have people to say that well, it's not like it was when I trained in the 50s. Okay? It's people who say, here are the variables that we have, and what can we do in our strategic planning, which we have done. And that's another, strategic planning is another milepost in terms of the institution, because the institution does have direction. And I want to give you a document today, which in fact is the template for the institution, which we've had published. It's called the Directions to the Future Tcm. All of these includes the goal statement, the service statement that worked through the faculty and worked through the staff, administration, and worked through it was approved by the board, and a research statement. So the direction of the institution is very clear for the next 5, 10, or 20 years. It's in place. And now we have to find the people, and we have to allow our students and our faculty and staff to believe that we are good. Okay? Because we are. And many of us find the warts. We're not looking at the great things that are happening.
There are always people that do that.
What accomplishments during your administration have brought you the most satisfaction? Wow. I guess that the establishment of those three, the ratification of those three documents, the reinforcement of the goal statement, which was done in 1980, that was redone in 1984 by the Board of Regents, the service statement and research statement that was put into place. I think that the economic impact statement, which has demonstrated that we've produced $50 million per year in revenue for Tarrant County, and I think that seeing the turnaround in attitudes of the students, and watching them share their pride in the accomplishments on external exams, watching the growth and proliferation of clinical opportunities for the college, and noting that we are a player at the federal level and at the state level, and looking at our stature grow consistently in the osteopathic arena. I also feel that I'm most satisfied that we are looking critically at those who we choose to become our colleagues in administration, faculty, and staff. In other words, we now can be selective to pick the cream of the crop from around the country, and we've done some of that recently. We'll continue to do that. Look for the best people to become a part of where we are, because the bricks and mortar are wonderful, but those aren't programs. The people are the programs. I think that I have tried very hard to change the fiber of the institution. And I think I've got a little bit of accomplishment there. We put the EAP plan in place this year, the Employees Assistance Plan for students and faculty and staff, which allow, because the workplace is changing, we have significant single parents working here. Okay? They have special needs. So we have in place a program where if they need legal counsel, or if they need psychological counseling, or if they need financial counseling, that with anonymity, we've signed a contract with a private vendor. With anonymity, they can receive that help to have them continue being in the workplace while they're resolving these problems.
Sure goes along with the wellness concept of a college, doesn't it?
Yeah. But more importantly, it's an attitude that I hope that will pervade through the institution, that we do care. And they're important, because it doesn't do us good to have a well-trained employee who gets into financial difficulty, or has a son or daughter who's on drugs, or a major divorce thing, and have them quit and go out of the workplace. On the other hand, if we don't recognize that problem, if they don't recognize that problem early and deal with it because they do not have the financial wherewithal to deal with it, then they end up not being able to do their job, quit, and then we have to train a new employee, which is more expensive. But I'm very proud of that. And I'm proud that people are starting to hear that the most important thing we have are our people. And I've said many, many times to my administrators, I said, you know, we all have to make tough decisions about people. And how things are done oftentimes are more important than what is done. You can talk to John about that, because he and I and other people have gone over that many, many times. it's trying to have the humanistic approach to dealing with people problems. I'm particularly proud of the institution. In fact, that we've taken the leadership probably in the nation of being one of the first, if not the first, medical school to have a complete ban on smoking.
Oh, yeah. Although some of your faculty spend time outside the door. One John Tcm.
Well, there are others.
I know.
But, and that, I took that to the students. I did a Medline search on smoking, and I took it to the student body and student leadership, and I said, what do you think? They came back and said, Dr. Richards, if we're who we say we are, in health-related professions, there's no choice that we have but to ban smoking. Then I took it to maybe 7 or 8 other committees with the same data, with that information, led by the students. And they came back and said, Dr. Richards, you have no choice. So on October 1, 2 years ago, we banned smoking and received a commendation from the Surgeon General on the leadership we've given to, I don't know of any employee that's resigned because of the non-smoking situation. What problems have had the most difficulty? I think that the overall problem is that attempting to have individual staff and faculty in administration believe that the most important thing in our life as an institution is our students. Okay? I say to the janitors, I say to the people that I meet with, and I meet with every section at least once a year and have a coffee with them and so on. I say to them, I won't be satisfied until you share with us our commencement in May or June. And you will say, I am a janitor, I am a truck driver, I am a physical plant individual, or I'm a secretary, that I really feel that I have made a contribution to this individual or this group collectively that crosses the stage and receives a DO degree. And my job is that. And I'm making a strong contribution, and I do care, and I do believe, and I'm proud to be part of the Texas College on Aesthetic Medicine, because what they are doing nationally, their reputation nationally, and what contribution that they're making within the state of Texas. That's the most difficult problem we have, because if I can get 75% of our faculty and staff to understand that that's their mission, then many of these other problems will be lessened, because we will have a full commitment of why we're here. And that certainly is an altruistic task, but it's not inconceivable. And that relates to making decisions on how we treat each other and how we treat other people, particularly the students and our graduates. I guess that's the biggest problem that I've got. At one time, TCOM saw itself as breaking new ground in medical education. The goal statement, the Institute for Human Fitness, core.
Much of that you've answered already.
Okay.
Except the Institute for Human Fitness, was that just that wasn't a philosophical?
No, that was an implementation phase. the Institute for Human Fitness was an implementation phase. The commitment for the institution continues to be, one, general practice, and not necessarily priority, but there are three areas that have to grow in order for us to continue the mission we've got. The Institute, the Department of General Practice, the Department of Public Health Preventive Medicine, and Department of Manipulative Medicine. Okay? There has to be a symbiotic understanding and relationship of those three departments as to where we are and the uniqueness of this institution. Every one of them has a mission that relates to why we exist. And they cannot be a single entity going in different directions, beating to a different drummer. There has to be an opportunity for them to contribute not only to the healthcare needs, but the educational needs of our students and our residents. They have to take leadership in the profession. And they have to contribute in a scholarly sense to core knowledge. And there's a deficit there. That has to grow. And that relates to the goal statement, and that relates to everything that's in the research document and our service mechanism. That doesn't mean that they grow in spite of other departments. But you have to have a foundation to continue that primary care base. We can't graduate 10% of our students that are going into primary care areas 5, 10, or 15 years from now. We have to continue the foundation, and that means there has to be leadership in that foundation who feel that sense of commitment and are willing to buy into that dream. Now, how it's implemented is only as good as the leadership in their creativity and their ability to dream what could be. But the template is it. Yes, the curriculum is still heading in that direction.
Why is there no Institute for Human Fitness any longer? Is that simply that was a phase we went through and it's not the most effective way to implement these goals?
The reason that there's not an Institute for Human Fitness is the fact that the state of Texas told us that we could not continue to use state funds to rent space at River Plaza. We didn't have the thousands of dollars per month of private money to do that. The people involved in the Institute did not choose to raise that money. So we had no choice. With the fact that we had a department of rehabilitation where the physiatrist chose to leave, we had to regroup. So we regrouped in the consortium, putting together, which was the original design of the Institute for Human Fitness to begin with, putting together three areas. 1, the rehabilitation area, 2, the public health area, and 3, the Institute. Okay? The function of the Institute, half the functions of the Institute are still in existence. They're doing wellness assessments and contracting with the city and police department with doing wellness assessments in terms of contracts for those in other private industries. The implementation phase of the Institute has been taken over by a prolifery of wellness centers all over Fort Worth, Harris Hospital.
Commercial, yeah.
Within 5 minutes from where we are here, there are at least 5 different wellness centers.
And they spend an enormous amount on mail.
Yeah.
Don't you get it at home?
Yes, I get it all the time. You got the YMCA's, you got the YWCA's, you've got the the Harris, you've got the St. Joe's, you've got the Hugleys, you've got the President's Fitness Centers. Those are implementation areas.
So you can say that we were a leader in that because
Very much a leader.
IHF was first, but there is not the community need for it now as such, but it's done first.
There probably is a need for it, but we can't use state funds on it. And Texas is unique in terms of some of the funding. For example, we can't use state funds for students or alumni. Other states can. So we're restricted. On the other hand, potential for us to do scholarly activity in relation to those hundreds and thousands of people that come through here to get their assessments, the opportunity to use that in some scholarly base and publish findings down the line, which will contribute to core knowledge, can in fact, in my opinion, give us the recognition and leadership that's necessary. Very similar to our friend in Dallas, who received his notoriety not on the basis of specifically his runner, but on the basis that he has the data to support that the quality of life improves. You get your lower cholesterol, you get your lean body fat, and you increase your cardiac reserve. All of those things have a significant impact on a person's longevity and quality of life. But the data that he produced gave him that recognition. I'm saying that with our leadership here, that we can and should have the quality people who can enhance that and give us the leadership again in the direction that we need to go. Okay. And what are the particular concerns for the future? I think the concerns for the future I mentioned some of that.
Mm-hmm.
Where is medicine going? Will we have a socialized system? Will we have rationing of health care? Will the health care cost continue to be an issue to the fact that influences what happens with medical education? I am concerned that we as a profession come together with an understanding that we can work cooperatively with other healthcare agencies, and we are symbiotic in that relationship, and take the advantage that we are the leaders and will make a significant contribution in the healthcare delivery system, not only in the state of Texas, but nationally, based on the quality of our programs and our areas.
Can you convince people that that can be done while maintaining your distinctive? Can you overcome the we're as good as mentality? The we want to be like that has plagued the osteopathic profession?
Well, that's a matter of attitude.
Yeah.
I don't know that I can convince people of that. Okay? I can only say that leaders lead and leadership starts at the top. And my message is that we're second to none in terms of our contribution. We're second to none in terms of the things that we're doing, and we can hold our own in any healthcare endeavor and can make a significant, unique contribution in a variety of different ways.
I think the unique is the key. As long as we can say what we do is different, but it's special and important.
If we're the same as, there's no need for us to exist.
That's good.
Because we can't compete in the same as, okay? And we also have to take risks. We have to open up new avenues. We have to take that risk to open up new avenues. And were we not willing to take the risk, and there are certain individuals who say, why are you doing it? Why are you doing this? We don't have the manpower. You're not going to get the manpower unless you open these things up. You're not going to get the space unless you have those needs. Okay? It's a chicken or egg. On one hand, individuals say, well, Dr. Richards, we need more graduate programs. Okay. I agree. How do you get those? We can create a paper trail for a new graduate program. But where do you get the patience to assure that there's quality? Okay? To interest our students and our graduates that we do have a strong program. Well, you do that through consortiums. Okay? And you do that by creating a clinical base. The VA and the Carswell have potential for like 350,000 potential patients. Okay? You got to think of those things in order to get the clinical base, which gets more faculty, which gets more state funds, which gets more graduate programs, which has more quality. Some of the individuals say, well, why should you go out here and why are you doing this, Dr. Richards? We don't have the manpower to do this. I get the manpower through state funds. And you go to the state, here are the needs that are unmet, and we need 10, 20 new faculty to do this. Mr. Governor and Mr. Lieutenant Governor and Mr. Speaker of the House.
You mean when you start in with Carswell, people said to you, wait a minute, don't do this. We don't need to take on any more programs.
I've got it right now. We don't have the manpower. We can't do this.
Yeah, I can understand.
But if you have the patience and you've got a quality educational program, you will have residents who are licensed, which can mean more faculty. How did the other medical schools build their faculty base? What we do is we look at ourselves and say, isn't it awful? Isn't it terrible? We don't dream on the potential for where the institution can be. I think the vision for our institution for the next 20 years, you can read the book. I think that our vision is to become an academic health center in conjunction with the assets of the University of North Texas, where we can in fact play a significant role not only in the economy of Tarrant County, but a significant role in the training of those individuals who will relate to healthcare delivery in the state of Texas. And I would hope that at that point in time that we have a full affiliation with John Peter Smith. I don't know if you want to put that in the book or not. But,
No, I think I'll leave the hope not be.
But I feel we will be with John Peter Smith.
Just increased affiliations with other healthcare facilities. Would you back up and tell me something about CORE today? John just mentions CORE and I don't understand it. I have Kim's interview about the establishment of CORE, and I understand. To me, it's like at TCU we talk about teaching writing across the curriculum.
Mm-hmm.
To me, it sounds like you're teaching osteopathic philosophy across the curriculum.
Okay. CORE is organizationally changed.
Yes,
It's back in manipulative medicine because the original function under which CORE was established was never fully implemented, particularly in the area of the interdisciplinary aspect of things, and particularly in the aspect of scholarly activity. Okay? And off the record, we're not competing with the other OSPAC schools in terms of what we're doing in OSPAC research. Based on our resources, based on our budget, based on the number of faculty that we've got, we're not the leaders in that area. So what we're trying to do is to bring CORE back into manipulative medicine and charging them very clearly that part of their responsibility is to do scholarly activity and take the leadership of where we are. Because what happens is, you've got people, we got a visit about 6 months ago from one of the physicians, an MD, who runs the Medicaid program in Texas. John knows his name. And he asked a question of Dr. Dickey and John and myself. Tell me, I've got a patient here with carcinoma of the colon. Tell me, Dr. Dickey, what data do you have to support that does anything for carcinoma of the colon? No answers. Okay. There are no answers. Now, certainly, we feel that as a practicing hospital physician, that there are things that can be done to help that patient, not necessarily cure the cancer,
Palliative.
but help that patient total well-being during that process. But Judy, I can't tell you anything that's been produced here at this school that in any way directs any answers to those questions. Okay? And we have to have a leadership to be able to do that. You know, we say we are unique in terms of the anesthetic concept. Fine. We say we're unique in producing general practitioners and primary care physicians. We've got a track record of that.
We don't have the track record of that.
No.
Okay, then I won't talk a whole lot about CORE. I'll just say that it's charged with scholarly activity. In a sense, is what CORE charged with the continuation of the work the modern updating of the work that Kim and Denslow started. I mean, it's a continuation of that tradition.
It was an interdisciplinary group that would bring together the people to continue the education of our faculty and to use and give leadership in interdisciplinary approaches to fulfill the anesthetic concept through 4 years, and it had a research component very clearly, of which we got 0 in research. And we got little in interdisciplinary things. But let me make a point. When you go into our hospitals and you see patients with asthma, they're laying over the bed and people are cupping them. The respiratory therapists are cupping them. And you ask the question, why are they not getting rib raising, and why are they not getting lymphatic pump, and why are they not getting what we think are the techniques that are necessary? Then I have to go back and say the reason is because somebody wrote an article someplace, somewhere, I don't even know the company's in vogue now, but somebody wrote an article someplace, somewhere on double-blind studies on the effectiveness in respiratory disorders of cupping and postural drainage in order to improve asthma or pneumonia or so on.
So we need the article that says rib raising is effective.
And lymphatic pump has, in a double-blind study of 300 patients who have had these diseases, that they have been effective and have that of such a quality that that's published in medical journals, prestigious medical journals. Okay?
Would make a difference.
It would make a difference. For our people to say, I've had 30 patients in my practice, and they've all gotten better by doing these things to them, and students respect that. Trust me, believe me, and go with God. And then they go and meet with our general practitioners, our internists, and say, Dr. Richards, I don't believe that your treatment of diabetes is acceptable here. I think that you should be doing whatever and whatever. And I say to them, let's go to the library. Let me pull out the latest that we have in terms of treatment of diabetes. Oh, okay. You're right, I'm wrong. You have a database. But the guru aspect and the laying on of the hands aspect with the quality of students that we have at this point in time, they won't accept. Trust me, it works in my last 30 patients, unless they've experienced that themselves.
Okay.
So there's a need for us to produce the educator in hospital medicine that can and will publish those results with double-blind studies. I'm convinced that they work.
That is then one of the goals of the college is to
I have given clear message to this college to give leadership in that direction. And to hire those people who have that initiative, who have that ability, and will give that commitment, because that's what we need, in my opinion.
What questions am I going to ask Dr. Hurley?
I think you should ask Dr. Hurley from his perspective on the strengths, the same questions you asked me, strengths and weaknesses. He often reminds me when I call him with a problem or tell him about a problem we've got, he laughs. He says, well, that's the the Air Force Academy 20 years ago when I was there.
You've mentioned
Talk to him about that. Talk to him about where our institution has been, what the changes are, where it's going, what's happened, why it's happened, what's the investment of the Board of Regents, what does he see as a future of medical education as it relates to the state of Texas.
Does he, as the chancellor of a large university, keep that much tabs on medical education?
Very attuned and very supportive. And he's a believer. I mean, he is a believer in wellness. He's a runner.
Oh, is he running?
Yeah. He eats right. His wife plays tennis. He's firm and committed. He's committed that we should have a niche. Okay? Very invested in preventive medicine aspect of things. He's one of our strongest supporters.
I'm going to have lunch with one of the preventive medicine people, Charles Ogilvy, and I guess this is his last real day here.
Charlie is a neat guy, and I wish he wouldn't leave, but...
Got his head tuned towards running a bed and breakfast and being a rancher, I think.
We'll all have to make those decisions at some point. Okay.
What have I left out? I just put that last in because I thought, you told me you want the committee to dedicate it, don't you?
Yeah,